Hello and a very warm welcome to this wonderful Now in this module we are going to talk about the National TB Elimination Program. Beta, you have already discussed about the epidemiological determinants and about the diagnostic modalities. Now let us have quick MCQs about this beautiful program that is the National TB Elimination Program. First MCQ, a little bit history. In 1962, we started with the National TB Control Program. We started with the National TB Control Program. We all know TB is an old-time public health problem. So for the first time, the program was started in year 1962. Then in 1997, we renamed the program to the Revised National TB Control Program, the famous RNTCP. What was the hallmark in RNTCP, beta? What do you mean by RNTCP? Revised National Tuberculosis TB Control Program. So what was the revised in this? What do you mean by the revised national tuberculosis? The revised was that we started with a big time treatment strategy that was called as the DOTS. What is DOTS? It is directly observed treatment short course. It is directly observed a treatment short course which was started in year 1997 with the revised National Tuberculosis Control Program. And then subsequently in year 2020, we started with our National TB Elimination Program. What are the features? How is it different from RNTCP? Very soon we are going to talk. So if I just show you this page, we have already talked about this slide that whatever I'm going to talk today about the strategies, about the targets and about the statistical, the epidemiological stats about tuberculosis, we all are talking about the India TB Report 2022. I don't know that you might be watching this video maybe in 23 or whenever, but the data could have been changed. So whatever I'm discussing today is about the latest 2022 data. Just to reiterate over here, I hope we all remember from our previous module that the tuberculosis incidence in India is 188 per lakh with the MDR cases and XDR on a slight decline, that is 4 per lakh and XDR is 1 per lakh. I would like to reiterate the point over here that we have already talked that the median age of having tuberculosis is roughly around 15-20 years till 45 years. It is the maximum, more in males compared to the females. We have already had on this. So this depicts that the theme of the World TB Day. The World TB Day, which is observed on 24th of March every year. The theme for year 2022 is to invest in tuberculosis so that we can save lives. And that is what I liked about this theme. Let's move ahead and talk about some more important MCQ point of view. What about the first topic, that is targets of the program? If we just have a look at the targets, I would like you to focus over here, beta, that if we talk about the targets on this side, these targets are the WHO targets. What is WHO? World Health Organization. It is the biggest daddy we have, big daddy of health in the world. So the big daddy wants, the WHO wants that by year 2035, the whole world should have end TB. That means, what do you mean by end TB? Please note, all things are important. By when does the WHO want? They want to end TB globally by year 2035. What do you mean by ending TB? That means we should have a reduction in TB deaths and we should have reduction in the TB incidence. Just remember these. The catastrophic cause due to TB, you can just forget. That's okay. It's always zero, right? But I want you to understand that we want to decline the TB deaths by how much? We want to decline the TB deaths. The WHO says decline it by 95% and you decline the TB incidence by 90%. So WHO targets are 95 and 90 by year 2035 for the globe. Now, based on the WHO targets, the the smaller daddy that we have is the Sustainable Development Goals. Please note that the SDG targets. Now, WHO says 2035. SDG wala says that, okay, you say 2035, we do it by 2030. You need to memorize this. So 2030, the SDG will be taking as the target year. You already know SDG started in which year? They started in 2015 and they will be working till 2030. Those are the targets. So SDG targets, but now what is the number targets? They want that there should be reduction in TB deaths. Listen very carefully. Now, this is what you cannot afford to forget in your exams. Beta, the SDG wants the reduction in TB deaths by 90% and not by 95 WHO. The case incidence should be decreased by 80% and not by 90% as per WHO. This is what is important from the SDG point of view. So SDG wants to decrease TB deaths. Say with me, you need to write it somewhere. Say with me, write it somewhere. TB deaths to be decreased by, please remember, TB deaths to be decreased by 90% and TB cases to be decreased by 80% by year 2030. Now SDG said 2030, our government of India got very happy. We said that they're saying 2030, let us eliminate TB by year 2025. What are the targets? It's the same targets that we follow because India is a part of the SDG system. So whatever SDG says, we will do. But SDG said that 2030, India says by 2025. So I would like you to remember in big words that what are the targets of the NTEP. The targets of NTEP are to end TB by year 2025. That is the commitment, that is the determination that we have. Please note, TB harega, desh jeetega. We want a TB Mukt Bharat. These are the slogans that we have. So that is very important. TB harega and desh jeetega. End TB by year 2025. What do you mean by ending TB by year 2025? We want to end TB. That means you decrease the mortality due to TB, mortality due to TB to less than 90% and to decrease the TB incidence to less than 80%. Catastrophic cost you can forget. So this is beta a 3 by 5 star MCQ topic for your exam. What are the targets under NTEP National TB Elimination Program? I would also like you to remember the new logo that we have. The new logo has a slogan. I don't know if you remember it from the previous slide that I showed you, that this is the new logo that we have. It's in circle. Earlier logo was that person with all big hands and the person had a different color on the body. So the slogan was Pura Course Pakka Ilaj. But now the slogan is TB Harega, Desh Jeetega, and it is a circular logo. This is the new logo for us. So please note that was one point about the logo. The second point was that in 2020, what extra happened? In 2020, we revised our revised National TB program and we started calling it as the National TB Elimination Program, or the strategy was to end TB now. When do you want to end TB? It is a very enthusiastic program. It's such an enthusiastic program with a lot of determination and a lot of funding and a lot of budgeting into the program. So what were the key features in this? We wanted to have very important MCQs, beta, I'm saying. So even if you're a UG student, you need to understand these words, because I know I'm very sure on this that all the students who are aspiring for their PG entrance exam, they would be understanding this. We wanted to have a UDST, that is universal DST, that is universalization of the CB-NAT. What we wanted was that the CB-NAT should be available to everyone. That was to promote CB-NAT. So that was UDST. It was also to promote Delaminid and Bedaquiline into the game. So now we are very happy to announce that we have the two new drugs for tuberculosis. That is, we have the Bedaquiline and Delaminid. Into the game. They are with us with the program. I'll shortly discuss what is happening where, but you need to understand these 2-3 important points. So now we have a shorter oral MDR TB regime, and we have a longer oral MDR TB regime. That is, we have included what, beta? Bedaquiline. So this is Bedaquiline. So that is one point for you to know. Second point is introduction of TrueNAT. Can you see this introduction of TrueNAT? I think I talked to you in the previous module that what is TrueNAT. TrueNAT was launched by the NTEB Diagnostics. It is from Government of India, and we are proud to say that TrueNAT is very cost effective, and in fact it is more efficient. But it is kind of easy and a cheaper version of the CBNAT. It is an Indian version of the CBNAT. So these were our plans for year 2017 till 2025, and these were our main strategies in year 2020. Next is this topic number 2. Topic number 1 we already discussed was the targets of the TB program. Now this is a 5 by 5 star MCQ topic. Very important. Very frequently they'll ask you question on this. First thing you need to do is, what do you mean by a presumptive TB case? If I talk about a presumptive TB case, earlier there was something called as a TB suspect. Do you know? If you talk to your seniors, they will say there was something called as TB suspect. Please note, under the program we do not use this word now. There's nothing called as TB suspect. It is a bad word to say. We do not have anything called as TB suspect. What do you mean by presumptive TB? Please note that presumptive TB is any person with complaint of cough or fever or night sweats, anything, okay? Night sweats. Please note, it is cough or fever or night sweats for more than 2 weeks. For more than 2 weeks, that will be called as a presumptive TB case. Presumptive TB case could also be any person who has a significant weight loss. Any person who has a significant weight loss over few months, it could be 1 month, it could be 3 months, but that is called as a presumptive TB case. So please note, you have something called as presumptive tuberculosis case. So beta, please note that what do you mean by presumptive TB case? Say with me, you have to write it with me here. So presumptive TB case means any person who has complaint of cough or fever or night sweats. It could be anything for more than 2 weeks. Very important. And or plus or minus the weight loss. Significant weight loss. Next is the tuberculosis. Please mind it that presumptive TB is a presumptive TB case. है ना? So that is also a TB case. But which TB case? That is called as presumptive. Any person who has cough for more than 2 weeks. Now in case a person is diagnosed with tuberculosis, now after diagnosis, now you can have 2 different types of TB. We can have a drug sensitive TB, or we can have simple answer drug resistant TB. What do you mean by drug sensitive TB? That means it was sensitive to rifampicin and isoniazid. If it is sensitive to rifampicin and isoniazid, we call it as a drug sensitive. That means there is no resistance. What do you mean by drug resistance? Any drug resistance. Any drug resistant will be called as drug resistant. So what do you mean by this drug resistant TB? Drug resistant TB could be resistance to any drug. We could have H mono drug resistance. What do you mean by H mono drug resistance, beta? H stands for isoniazid, right? So it is only isoniazid resistance. If there is only isoniazid resistance, that is called as H mono drug resistance. What do you mean by multi-drug resistance? It is resistance to H and R or H or R. What do you want to say? It is multi-drug. It is multi-drug. It is H and R both. At least 2. It is at least 2 H and R. It could add something else also, but that all is called as a MDR-TB, multi-drug resistant tuberculosis. What do you mean by polydrug resistance? Polydrug is any 2 drug resistance, not including H and R. Not including H and R, any other 2, you could have H and Z, you could have Z and E. So any other drug resistance, that is a polydrug resistance. Now there is kind of a problem over here. What do you mean by MDR XDR TB? What do you mean by MDR? We already discussed MDR does not mean a monodrug resistance. MDR beta we just now discussed. MDR means a multi-drug resistance. What is a multi-drug resistance TB? Multi-drug resistance TB, that is H and R, just now we discussed. What do you mean by XDR TB? Please note that XDR tuberculosis is H and R resistance plus any fluoroquinolone plus any, what do you want to say? Any second line injectable. This is old answer. It is gone now. It is any group A drugs. Resistance to, please listen to the language. This is updated. This is a new thing for us. What do you mean by XDR-TB? XDR-TB is now defined as resistance to H and R, that is multi-drug resistance, also resistance to fluoroquinolone, and also resistance to group A drugs. That's a new classifier. What do you mean by the group A drugs? The drugs have been categorized now into group A, group B, and group C. In the group A, you have the levofloxacin, you have bedaquiline, and you have linezolid. Which are the drugs, beta? You will have levoflox or moxiflox, we will have bedaquiline, and we will have linezolid. Which are the three groups? Fluoroquinolones, levoflox, moxi, linezolid, and bedaquiline. So that is what we call as a XDR-TB. What is this now? Why did I do like this? There is again a new category now of definition of tuberculosis, of drug-resistant tuberculosis, that is called as a pre-XDR-TB. What do you mean by pre-XDR-TB, beta? It is resistance to H and R plus it is resistance to any fluoroquinolone. So now the problem starts. What is the difference between XDR and a pre-XDR? Pre-XDR is a resistance to, listen carefully, I'm trying to solve a controversy over here. Pre-XDR, beta, is a resistance to H and R plus it is any fluoroquinolone. It could be levoflox, it could be moxiflox. What do you mean by XDR? XDR is resistance to, listen carefully, XDR is resistance to H and R plus any fluoroquinolone plus any group A drugs, which is including the bedaquiline and the linezolid, because common sense, the fluoroquinolone has gone into the fluoroquinolone category. Are you getting it? So please note, in pre-XDR, you can have H and R plus a levoflox resistance that will be called as, that will be labeled as a pre-XDR. So in case we have a bedaquiline or a linezolid resistance, only then we label this as XDR. That is, what do you mean by XDR? XDR stands for extensively drug resistant tuberculosis. Please note, it does not stand for, it does not mean extremely drug resistant. We don't say extremely drug resistance. It is extensively drug resistant tuberculosis. That is the definition you would like to remember. Next is, there can be another MCQ, that what do you mean by a presumptive MDR case? But we have already studied that. What do you mean by the presumptive TB case? Presumptive TB case is any case of fever or night sweat or weight loss or any case of cough, of course, for more than 2 weeks. That is a presumptive TB case. Now, what do you mean by a presumptive MDR case? The presumptive MDR case could broadly have four categorization. So if you talk about a presumptive MDR case, the first presumptive MDR would be any person who is having ATT for more than 1 month, and then he leaves for more than 1 month. That is, there is a default for more than 1 month. This is called as a loss to follow-up. If there is a loss to follow-up, that is called as a presumptive MDR suspect or a presumptive MDR TB case. Next is, the presumptive TB case could also be any person who's currently on ATT. What do you mean by ATT? Anti-tubercular treatment. So a person who's currently on ATT and they show a poor response. What do you mean by poor response? That is, there is no clinical improvement, or the person is still sputum positive at 3rd or the 5th month of follow-ups. So that is called as a presumptive MDR. Also, any contact of the MDR, case, that is also a presumptive MDR case. Last is, a presumptive MDR case could also be any person who has a recurrent TB. What do you mean by recurrent tuberculosis? Earlier, do you know that we had a relapse of TB? What do you mean by relapse? Relapse is any person who took TB treatment and was finally cured of TB, and then he got a sputum positive again after declared as treatment cured. So once you complete your treatment, then you should be fine. But in case you still get sputum positive after getting a complete declaration that you are cured, that is a relapse of TB. That word relapse is gone now. We do not say relapse. We have replaced the word relapse with the recurrent TB. So please note that there are a couple of things for you to know. In presumptive MDR, what is a presumptive MDR case? A person who took ATT for more than 1 month and then there was loss to follow-up. A presumptive MDR is also a person who is relapsing, that is cured after ATT and now he is microbiologically confirmed again. Presumptive MDR is also a person who has contact of MDR or who was on ATT and shows a poor response. So that is an important frequently asked MCQ to you, that who will be our MDR suspects. So that is technically called as presumptive MDR. I'll use everything, all the definitions that I have taught to you right now, they will be used very soon in the program. Topic number 3. What are the diagnostic modalities? Please note that in the previous module, you already discussed about various diagnostic tests which we use in tuberculosis. Now, all those tests we are going to use that how strategically we are placing them under the National TB Elimination Program. There is a system, there is an algorithm over here and all the healthcare professionals are supposed to diagnose TB only using that algorithm in India. So if you talk about the diagnostic modality, beta, you will have something called as a presumptive TB case. So we will have a presumptive TB case. What are we going to do to this presumptive TB case? Who is a presumptive TB case? Any case who has cough, fever or night sweats for more than 2 weeks. So beta, to this person, we are going to do sputum testing plus the NAT testing plus the chest X-ray. This is a drastic major change that we have from the previous system, from the previous guidelines that we used to have till year 2021, that we used to do only sputum testing and chest X-ray, and then in the next level we used to do NAT testing. But now the program wants a universal NAT testing. What do you mean by NAT? NAT actually could be of various types. We can have a cartridge-based nucleic acid amplification test. We already discussed all this in the last module, right? Or we could talk about the true NATs. So we can have a true NAT, or we can have a cartridge-based nucleic acid amplification test, that is the CBNAT. So at the first level, we are going to do a sputum and a CBNAT and chest X-ray. There are two understandings over here. India is a big country. In case you are working in a rural area, in rural area, you don't expect that we'll be having a CBNAT over there in that village or in that town. In case CBNAT is not there, at least you should get a sputum test done. So this is the minimum requirement now. In case you're working in big towns or big cities, or you're working in Delhi, Mumbai, metropolitan people, so there you will have CBNAT facility. In case you have both the facility options, then the preferred option is a CBNAT. Did you get it? The minimum is sputum and the preferred is CBNAT. I would also like to tell you that sputum is highly sensitive and specific test. CBNAT is highly specific and a sensitive test. So you do sputum and CBNAT together. Now, in case that person is going to show you either sputum negative and the NAT is also negative. What do you mean by this? If the sputum is negative, NAT is negative and the chest X-ray also is normal, it doesn't show anything. What does it mean? So now that patient who had cough or fever or something, you should rule out TB. Rule out tuberculosis, send that patient to the medical officer, to your seniors, and they are going to diagnose, because all this diagnostic modality I'm telling you at a lower community level. So this happens at the village level, at the sub-center or the PHC level, or maximum at the CHC level. So we rule out TB, and maybe this patient could be a clinically diagnosed TB, but technically this patient has shown no NAT. If NAT, nucleic acid test, is not there, that means what? The nucleic acid is not there, so that means that patient does not have TB, right? Now the problem starts that if the patient is sputum positive and if the patient is NAT positive. NAT positive means the Mycobacterium TB detected. This patient is called as a microbiologically confirmed TB case. So it is very simple now. So if you get a patient who is coming with cough and fever and everything, you simply go for a NAT test if NAT is available. If it's not, go for a sputum test. In either cases, in case you get a Mycobacterium TB detected, now what are you going to do? So now what we do is that this is the algorithm. It's a very simplified algorithm. You have a presumptive TB case. Presumptive TB, you're going to do the NAT test, the microscopy and the chest X-ray. Now that patient who is showing this diagram, technically I'm talking only with the MTB detected, right? In case the MTB is not detected, that is common sense, the TB is not there. TB is ruled out. Why? Because the NAT is negative, right? So you send that patient to the medical officer, to your senior, in case the patient still persists with the symptom, but this program does not take care of this. In the program, we are talking of the TB detected. Now the TB detected, the NAT. We talked about this in the diagnostic module also, that what is the biggest advantage of NAT, which I personally love, is the rifampicin. If it will tell you about the rifampicin sensitivity or the rifampicin resistant. In case the patient is rifampicin sensitive, to this patient, you are going to send that patient to the health facility, to the nearest medical officer in case you're working at a lower level or the health worker is diagnosing. And then we start with what regime? We start with the drug sensitive TB regime. The patient is automatically sent to the supporter, TB supporter, and the contacts of TB will be screened. Are we done with this? Very simple. This program has actually simplified the diagnostic guidelines. Next in line, if you see about the rifampicin resistant. Now, in case there was a rifampicin resistance, now you understand that there is some hanky-panky things which are going on. Now you cannot start the treatment until and unless we get a LPA done. What do you mean by LPA? LPA stands for the line probe assay. We did it in the last module, previous module. LPA stands for the line probe assay. So now we are going to send this patient for the first line probe assay, that is called as the FLLPA. And the second line probe assay, that is the SLLPA. First line probe assay is going to test for which resistance? It is going to test for isoniazid resistance. And the second line is going to test for all the second line drugs, the group A, the group B, and the group C drugs. So you have this different answers now. In this, depending on the drug resistance, you will have different answers, like there could be H mono polydrug resistance. There could be rifampicin resistant tuberculosis, RRTB, only rifampicin. There could be MDR-TB, H and R resistance. There could be pre-XDR, or there could be a polydrug resistant, or there could be a XDR-TB. Right? There could be different types of TB. So now we understand that these are the different types of TB and different types of regimes will be there. I'm shortly going to discuss what regime to give in what situation, but these are your definite answers for the regime treatment for tuberculosis. Next in line, you have another algorithm which has been recently launched in year 2020 for diagnosing a MDR suspect or a presumptive MDR cases. Beta, in case, listen to it carefully, there are two things over here. In case that person was isoniazid and rifampicin resistant presumptive TB, that is MDR TB presumptive, or in case that patient was previously drug sensitive and he is non-responder follow-up. You understand this whole category is what is the presumptive MDR. Are we getting it? So in case a person is H and R resistant presumptive, or in case the person was already as MDR presumptive case, now to that the first level is not sputum. The first thing we do is a NAT test. Very important. So now this NAT test should be a repeat NAT test. What do you mean by a repeat NAT test? Beta, try understanding that if the patient was a presumptive MDR case, like a contact of MDR. So in case of contact of MDR, you are going to do at the first level what? You are going to do NAT testing. That NAT test will be done for the first time. Now in case I'm talking about the presumptive MDR case who is actually a loss to follow-up. So if he is lost to follow-up or he is a non-responder, in the previous diagnosis, in the previous drug-sensitive TB, he must have got a NAT test done. Na? So that's what I'm saying, that don't rely on that previous NAT. Now you have to do a fresh NAT test again. So it could be the first time, it could be the fresh NAT test, but whatever it is, you have to do this nucleic acid amplification test using the CB-NATs. And now you will also send this patient directly for the first line LPA. Now this patient could have different answers. Either this patient is rifampicin sensitive and H sensitive, like this lucky person who was a contact of MDR. Let us say that he got some TB from somewhere else also. So now he is a lucky person, H sensitive and R sensitive. You directly give him the drug sensitive TB regime. Simple. But now, if the problem starts, if the problem is that this patient, let us say, is any drug resistance, either this patient could be rifampicin resistant, or this patient could be isoniazid resistance, or this patient could be both resistance, either rifampicin or isoniazid or both resistance. In cases it is both resistant or any resistant, any one, then you send the sample for the second line LPA also. You remember SLLPA, that is you're going to check for the second line drugs, and now again that problem will start. Either we will have a H monodrug resistance or a rifampicin resistance or MDR or pre-XDR or poly or a XDR resistant TB. Same answers. I hope you now understand it's very easy to diagnose TB under the NTEP algorithm. You have a presumptive TB case. You simply go for the NAT test as the first line plus the sputum. So now sputum is taking a second stage now. NAT test could tell you either that patient is TB detected or that patient is no TB. If the NAT test is negative, that means no TB. Now that patient who is TB could be RIF positive, that is RIF sensitive, or he could be a RIF negative or a RIF resistant. In case it is RIF resistant, go for the LPAs. You will need to go for the first line and the second line LPA. In case it is RIF sensitive, we start with the drug sensitive TB regime. Now this drug sensitive TB regime, this person will go on in his life. He will start taking the drug sensitive, and in case he responds, that is very nice, happy fellow. He is happy, family happy, everybody happy. Now in case he lands up into non-responders or any contacts of MDRs, they will again go for the LPA, and based on LPA, we will define the new treatment, whether it is MDR treatment, you want to give the RRT treatment or the XDR treatment. So this is as simple as the regime that we have. This since my UG days, I would say that for the first time in so many years, in the last 2 decades probably, that for the first time the TB's diagnostics has been so much simplified that we are very proud to say that TB diagnosis is an easy system because of the availability of the NAT test. That is the most important step that we had, NAT nucleic acid amplification test. So now, before I take on this topic of the treatment, I need to enter into this to see that what treatment to be given in what situation. Right? So now I am diving into the algorithm. Now it may slightly, 2 points only, may get slightly complicated. Look at this diagram. Do you understand anything? This is what we call as the integrated DRTB. So this is the integrated DRTB management, integrated drug resistant TB management regime. I know you won't be able to see anything. I don't want you to strain your eyes right now because I am going to zoom in. I want you to just look at the overview of it, that there could be some TB suspects and you are doing NAT testing. You are doing NAT test in them. Just have a look till now. So if you do beta NAT test, the person may either be a rifampicin resistance not detected, that is the green color, or this patient may be a RIF resistant strain. Now let me just go into this RIF sensitive area. If I talk to you about the RIF sensitive area, I zoomed into that RIF sensitive area. Now that patient was a MDR suspect, that patient was a presumptive MDR, and this patient, we did the NAT test and by chance it is a RIF sensitive. Now to that NAT test, so now before we go into the treatment modalities, I would like you to have a little bit more understanding overview of it. What are these people? I told you that these are the MDR cases. You will find H monodrug resistance, you will find MDR resistance, XDR resistance. So what a treatment to give in what situation will have to be understood right now. Let me just dive into this zone. I'm diving into this zone and there will be some complications over here. Look at this diagram over here. What is this diagram? It talks about the integrated drug resistant TB management. So it is a DRTB regime. We call it as an integrated DRTB regime. So don't just skip this topic. I'll make this whole algorithm, which might be very small in your screen right now. I'll zoom into it and I'll try to make this whole algorithm very simplified for you. Just have a look at it. So what is this DRTB algorithm? Can you see that these are the total MDR suspects over here? So at the first level, you are going to have the MDR suspects. That is what we already talked. To them, we do the NAT testing. That is what we already taught. NAT will give you what? It will tell you whether the patient is RIF sensitive. This patient is RIF sensitive or this patient is RIF resistant. Am I correct? That is what we had learned, right? So I'll just make one color as green, another as red. So I am trying to zoom into this area now, that what do you do with the RIF sensitive MDR presumptive cases. So that this is what this integrated DRTB, this is what is the green zone. And now I'm going to show you the green zone over here, this zone. So if you just look at this green zone, this is, I zoomed into this algorithm. Can you see that the person who is RIF sensitive, rifampicin sensitive, to them, what are you going to do? To the RIF sensitive people, we are going to do the first line LPA. This first line LPA may tell you whether it is H sensitive. So now what is the profile of this patient? Can you tell me what is the profile of this patient? This patient is H sensitive and R sensitive. Yeah, right? Because it is rifampicin sensitive. So now what is the drug treatment you are going to give? You are going to send this to the DSTB management. Okay. Now in case this was H resistance, in case there was H resistance, what is the profile of this patient? The profile of this patient would be H resistant and this is a rifampicin sensitive. Right? So now to this, what is the drug that you are going to give? H mono drug resistant TB regime. But before giving the H mono drug resistant TB regime, you see H mono drug resistant, we also do the second line LPA testing. And we start this patient on the H mono DRTB regime. This is very clear, very simple. Are we getting it? So we started with the CBNAT. CBNAT is the most important critical step in this whole game. So rifampicin sensitive or resistant, if it is sensitive, you test for the isoniazid. If isoniazid sensitive, you give the DSTB. If isoniazid resistance, you give the H mono polydrug regime. Done. Now come to the other arm of this complicated story. So I'm on this area now. I need to talk about the rifampicin resistant detected. If you talk about the rifampicin resistant detected, what are we going to do now? In patient who is very simple again, it's not at all complicated beta. In case the patient is rifampicin resistant, you should check for the isoniazid and the second line both. So you do the LPA for both the first line drug, that is isoniazid, and the second line drug, that is all the group A, group B drugs. Now based on this, you may find some resistance. Now listen carefully, that is what I wanted to show you over here. In case, this is the new update beta, 2022 update I am talking. 2022 update. So in case this patient is, listen carefully, in case this patient is on the first line, we found out that this is H resistant. This is isoniazid resistance. What is the profile of this patient? This patient is now R resistant, rifampicin resistant and H resistance. Now this H resistance could be because of two gene mutations. This could have two gene mutations, that is we are talking of the INH A gene, or this could be a CAT G gene mutation. If these both mutations are not there, like any one of them, either INHA or the CAT gene, not both. So in case in this rifampicin resistance, there is only one gene mutation in the H. If there is only one gene mutation, or there is H sensitive rifampicin resistant, to both these cases, what is this called as? This will be called as a RRTB. This is rifampicin resistant, right? And H sensitive. Or even if there is H resistance, only one gene. Which gene? Either INHA or the CAT gene, but not both. To this patients, we are pleased with folded hand. I would like you to understand this point. This is super duper important point. Beta, if you did not understand, stop the video, go back and try understanding it again. That I am talking that in cases of rifampicin resistant TB and in case of single gene mutation isoniazid resistance, we have started with the new drug regime. What is the new drug regime? That is called as a shorter oral bedaquiline regime. Shorter oral bedaquiline regime. So now the wonderful thing is that even for the MDR TB cases, what is MDR? It is H and R resistance, isoniazid and R. Earlier we were giving injections. Now this is no injections, we have the oral regime. That is what is the beauty of the NTEP, that we wanted to have launch of bedaquiline and delaminid into the program. So now we have the shorter oral, no injectable, shorter oral bedaquiline containing regime. Who is going to get the bedaquiline containing regime? Say it with me. Till the time you don't say, don't proceed further. Please note that who is going to get the shorter oral bedaquiline containing regime? We are going to give to, please say with me, we are going to give to RRTB. Who is RRTB? That is only rifampicin, no other gene detection, no other mutation detected. Or in case of MDR-TB with R resistance and single gene mutation, either INHA gene mutation or the CATG gene mutation with the isoniazid. So it is MDR with RR plus single gene H resistance. Are we clear on this? Only these are the patients who are going to get the shorter MDR, oral MDR or the bedaquiline containing regime. So now let us come to the other arm. If I talk about the other arm, just have a look at the screen carefully, beta. I know I'm short of space, but that's how it is. I'm sorry for my small writing in this screen, but anyways, if you have any feedbacks, you're most welcome to put it on your application. Beta, please note, let us come to the other side. If I say that this patient is already rifampicin resistance plus for the isoniazid, he had both gene mutations for the H resistance. Are we clear on this? If there is both gene mutation with the rifampicin or there is any fluoroquinolone resistance, or there is any fluoroquinolone resistance, in these cases, we have different options now. Okay, two options I'll tell you. So in this cases, beta, we can either give, that is the first option, we can give all oral, that is the name. It is all oral bedaquiline containing regime. Bedaquiline containing regime, also called as the MDR XDR regime, or we can give any optimized basal regime. What do you mean by optimized basal regime? That we will do the drug sensitivity testing, and based on the drug sensitivity testing, you're going to give the particular drugs that this drugs should be given, and these are not given because they are resistant. So in what situations, beta, you are going? So beta, now just to summarize, in what situations, can you help me in writing over here? In what situations are you going to give the all oral longer bedaquiline containing regime? To which situations? You are going to give to, in case the person is rifampicin resistant and both gene mutations, or any fluoroquinolone or any other drug mutation, you're going to give the all oral longer bedaquiline containing regime, or you give the optimized basal regime if that doesn't work. So now you have understood many different regimes over here. In the next section, in the next part, in the next topic number 4, we are going to talk about regimes. But I would like you to take a note of all the regimes that you have studied. Beta, you have studied about the drug sensitive TB regime. Am I correct? Then you studied about the H mono drug resistant TB regime. Then you studied about the shorter bedaquiline containing oral regime, that is the new regime. And then you studied about the all oral longer bedaquiline containing regime. And then you have a optimized regime, which has no regime, like you do whatever the DST, drug sensitivity testing people will say. So now it will be easy for you to understand that what treatment you're giving in what situation. Shorter bedaquiline, please note, is given only for the single gene mutation. In case of double gene mutation, you should switch over to the longer regime. Let us talk about the regimes now. Very simple. So if you talk about the treatments, now comes the treatment point. If you talk about the treatments, this is the simplified table that I have made for you. This is a common table where you will get a lot of MCQs. You need to understand better that there is a drug sensitive TB regime, and then there is H monopolydrug regime, you remember. Then there is a shorter MDR containing regime or shorter bedaquiline containing regime, and then there is a longer MDR oblique XDR regime. Longer MDR or XDR regime. Are we getting this right? So now it is very easy. What is the drug schedule that we have for drug sensitive? You have to cram this up. You have to ratify this. You will have to ratify this. What do you mean by all these alphabets? Can you understand these alphabets on the screen? I think, of course, yes, most of you must be able to understand H, R, Z, and E. What is HRZE? Isoniazid, rifampicin, pyrizinamide, ethambutol. So in case of drug sensitive TB regime, we are going to give intensive phase and we are going to give the continuation phase. The intensive phase is going to last for 2 months. What is this 2 written, beta? This 2 means the months. This 2 means the month. And H, R, Z, and E. What is HRZE? Isoniazid, rifampicin, pyrazinamide, and ethambutol. It is given as daily tablets. These tablets are always FDC. What do you mean by FDC? FDC stands for fixed dose combination. So what do you mean by the fixed dose combination? That means it is in single tablet we are going to give the H, R, Z, and E, everything together. That is called as FDC. It is fixed dose combination. It actually standardizes the treatment modality, because if there is one doctor, he says that I don't want to give rifampicin, I want to give half dose rifampicin. That actually generates problem. That will actually generate more problem. Right? Because it will cause drug resistance. So we have standardized this regime. It is a fixed dose combination. HRZD, 2 months they have to take intensive phase. And then for 4 months, they take the HR and E. So please note 2 months of HRZD and 4 months of HRE. In case of H monopolydrug regime, it is 6 months of 0. 6 months of 0. What do you mean by 0? ZERO. 0 stands for pyrazinamide, ethambutol, rifampicin, and O stands for levofloxacin. O stands for levofloxacin. So you can remember it as 6 months of 0 regime. It is much easier to remember about 0 because that is given for isoniazid resistance, H monopolydrug regime, right? Next is shorter MDR. Shorter oral bedaquiline containing regime. You can remember this as shorter oral bedaquiline containing regime. This is the new regime. So it is given to all cases who are rifampicin resistant, or it is also given to people who are single gene isoniazid resistance. The drugs that you can remember it as CHOP-Z. So we are giving 4 to 6 months of CHOP-Z plus 5 months of CHO-Z. What is CHOP-Z? C stands for clofazimine. H stands for high dose isoniazid. O stands for, as usual, my O is levoflox, right? O does not stand for ofloxacin. My O stands for levofloxacin. Please note that in case you are studying from previous books or old books might say moxiflox. This has been changed last year. It is levoflox now instead of moxiflox. So it is levoflox, right? So C, H, O, and B stands for your favorite answer, bedaquiline. Z stands for pyrazinamide. Z is pyrazinamide. E stands for ethambutol. And E stands for ethionamide. Okay, so that is your CHOBZEE, CHOBZ regime. So in case we are giving for the next 5 months, we are giving COZY, clofazimine, levofloxacin, pyrazinamide, and E stands for ethambutol. It's not the ethionamide, ethambutol. So that is we give for CHOBZ and 5 months of COZY. It is a massive big transition because earlier people used to take for 1 year or 2 year for MDR TB. Do you remember? Like your seniors must be knowing it, that for MDR we used to give injection kanamycin, amikacin. So just imagine they had to come alternate days for that kanamycin injection for roughly 1.5 to 2 years. That is a big torture. So what will patients do in case we give them this type of medicines? You tell me. Now I hope you will understand this. That in case, let us say that you as a doctor, how many days of antibiotic do you take in your home? Tell me with your true heart. Normally we take like 2 days, 3 days amoxi. Technically we should be taking for 14 days, 21 days. Na? Do you ever take it for 14 days? No. Why? Because we feel okay after 2-3 days. We just stop taking antibiotic. That will increase what? Over time. It will increase what? It will increase antibiotic resistance. And do you know that a patient who is already with TB, who has lot of TB, lot of weight loss, and he cannot eat, he can eat only half chapati every day. Half chapati, that also very badly he will take. That is so severe weight loss. And that patient is already low socioeconomic status. You start them on ATT and very soon within next 5-7 days they become okay. Why? Because the drugs are very effective. Do you know that if a patient is started on TB, started on ATT, do you know that the patient will become 50 to 80% non-infectious? That is the beauty of our drug. Patient will become 50 to 80% non-infectious within how much time? Within 48 hours of taking rifampicin. Is such a beautiful drug. Within 48 hours, the patient is 50 to 80% non-infective, and by 2 weeks, the patient is more than 95% non-infective. But the problem is that the patient is only 95% non-infective, 5% chance are still there. Now, if the patient does not take treatment, the TB bacilli comes to know that rifampicin had come and kicked me. So now it makes rifampicin resistance. So now if this patient, you understand that patient will be ready back to his life in 7-10 days. So now if the patient is healthy, why on earth would he take this treatment for so much time? He has to take HRZE. That is what the program is trying to do, that we want to stop any defaulters. If we stop defaulters, the whole system, we have very good drugs, but the good drug has to be taken for minimum some time. So I hope you understand that why the government shifted from injectables to oral, so that to increase compliance, it increases the compliance. So people will at least take the drug. So that is what it does. So for how much time the shorter MDR regime we are giving? We are giving for 4 months to 6 months. Please note why do I write 4 to 6? Because this can be extended to 6 months. Bedaquiline is always given for 6 months. So total bedaquiline will be given for 6 months. 4 to 6 months we give the CHOBZ, and last 5 months we give the COZY. Are we clear? The shorter bedaquiline containing regime can be remembered as, for 18 to 24 months, we are giving L2C2B. L2C2 stands for levofloxacin, linezolid, clofazimine, cycloserine. C stands for cycloserine. This C stands for cycloserine and B stands for bedaquiline. So it is given for 18 to 20 months. So this is also oral. The wonderful thing is that even XDR treatment we can do with oral drugs. The MDR treatment we can do with oral drugs. The drug sensitive TB we can manage with oral drugs. There are no role of injectables right now under the program. All the states, all the districts and the states, they are transitioning towards the new oral containing drug regimes. So this is what I was trying to tell you in the CHOBZE regime. This is the CHOBZEE regime. We give it for 4 to 6 months. What do you mean by 4 to 6 months? That the bedaquiline is extendable to 6 months. It is already extended to 6 months. And for 5 to 9 months, like it's a total 9-month regime. In the 5 to 9 months, you are going to give, for 5 months, we are going to give the COZI. And for 4 to 6 months, we give the CHOBZE, clofazimine, high-dose isoniazid, levoflox. O stands for levofloxacin, bedaquiline, pyrazinamide, ethambutol, and ethionamide. For all the students who want to still learn a little bit more is this chart. You can remember the fixed dose combination dosage chart. But for all the students who are working on the minimum needs program, at least beta, you can remember that the drug sensitive TB regime is always given in weight bands. So the person will come in some weight category. This is for adults I have shown you. This is only for the adult weight bands. So how many weight bands do you see? MCQs on this. How many weight bands do I see? I see 5 weight bands. So these are the minimum questions that you should remember. The FDC is having 5 weight bands. Second point for you to note is that what is the FDC meaning? Please note that the FDC stands for fixed dose combination. FDC stands for fixed dose combination. The fixed dose combination we could give for H, R, Z, and E. H is given at the rate of 75 milligrams, R is given as 150, Z is 400 milligrams, and ethambutol is 275 milligrams. So we give 2 months of H, R, Z, and E. Then we give 4 months of H, R, E, which is 75 milligrams, 150 milligrams, 275 milligrams respectively. You just remove off that 400. Are we getting it? This is what is the FDC regime. This is what minimum you should know for your exam. This is a 3 by 5-star MCQ topic for FDCs. Please note how many weight bands were there. There were 5 weight bands. You can also remember that how many doses do we give? In doses that we give in the intensive phase or in the continuation phase. In the intensive phase, there are 56 doses. In the continuation phase, there are 112 doses which are given to all adults. So you can just remember it from this table, the number of FDC tablets we give. So number of doses that we give for intensive phase, 56 doses. And for the continuation phase, we are giving 112 doses, and the FDC contains that same answer, 75, 150, 400, and 275. And in cases we are giving of the HRE, 75, 150, and 275. In case you are very enthusiastic and you want to learn about the child also, please note that in pediatric TB, you are going to have how many weight bands you can see? There are 6 weight bands. There are 6 weight bands. What is the FDC schedule or the dosage chart that you want to see? H, R, Z, and E. There is one difference in the pediatric weight band. In this weight band, in the adult thing, I told you that one tablet is going to contain H, R, Z, and E. In the pediatric beta, in the child, we give only H, R, and Z. E is always given as separate tablet. So it is not a part of the FDC tablet. So there are 2 tablets for this child. So there is a HRZ tablet and there is a E tablet. Okay. So what is the dosage in the HRZ? We have is 50 milligrams. R is 75 milligrams. Z is 150 milligrams. And the ethambutol comes as a separate tablet. It is 100 milligram tablets. Different age groups will get differently. You don't need to bother put your brain under stress. So please note that for the child also we are giving 2 months of HRZE. So how many tablets? The child will take 2 tablets plus they will take 4 months of HR and E. So how many tablets? Again 2 tablets. But the continuation phase tablets will contain only the HR and E component. So E is always separate. Are we done over here? The dosage remains the same beta. Dosage number remains the same. For intensive phase, it is 56 doses. For the continuation phase, it is 112 doses because the schedule is same. the weightage in that changes. And please note, in the pediatric category you have 6 bands. If you are still nerdy about it, you can just have a look at this table if it makes you any sense to you. But please note that the ethambutol is separate tablet, HRZ is separate, and then you have this is by mistake, this is not 150. So just remember, the HR tablets are 50 and 75 and the ethambutol is 100, and that's how you give in different weight bands. Next is, if you just want to have a look at this, of course, this will not be asked in your exam. Just for your information, beta, this is the shorter oral bedaquiline containing regime that you see. So it is given in different weight bands. You can see that there are how many weight bands in the shorter? 4 weight bands are there. So 16 to 30 kgs, 30 to 45 kgs, 46 to 70 kgs, and more than 70 kgs. In different weight bands, different drugs will be given. You remember the CHOP-Z regime. I would like to bring to your attention over here only for bedaquiline. Bedaquiline, I told you, is supposed to be out of this 4 to 6 months of CHOP-Z. You remember? And 5 months of COZI. The bedaquiline irrespectively was given for 6 months. Please note that bedaquiline is given as 400 milligram daily, and it is also given for the first 2 months, for the first 2 weeks, and then in the subsequent all the time. It is given only 3 times per week. It is the only drug which is not given daily. Other drugs are all daily except bedaquiline. Bedaquiline is given 3 times a week after second week. For the first 2 weeks, it is given as daily dose 400 milligrams. Otherwise, it is on 3 times weekly dose. So that almost completes most of your questions from diagnosis and treatment. Some of the treatment which are asked in special situations. So question number 1, apart from the normal adult and the child TB, we can ask you, like the MCQ examiner can ask you about the pregnancy and tuberculosis. Please note that all the bedaquiline containing drugs, they are safe in pregnancy. So whenever we get a pregnant female, we are supposed to ask that pregnant female that is the pregnancy more than 20 weeks or less than 20 weeks. If it is less than 20 weeks, the first advice that is always to advise for medical termination of pregnancy. In case the female says, no, I want to keep the pregnancy. If the female says, no, I want to keep the pregnancy, in those cases, we start that patient on oral longer bedaquiline containing regime, because that is considered to be slightly more effective. In case the MTP is done, then we can either switch that patient to shorter or longer, whatever we want. But the regime of choice, in case the female wants to continue pregnancy, has to be longer regime. Please note that in these situations, we do know the teratogenic effects of the drugs are there. But all said and done, tuberculosis is a public health problem that takes kind of more weightage than the pregnancy and the teratogenic effects. But all said and done, this has to be counseled to the female that there will be teratogenic effects and the drugs have to be taken. So in case the female is unwilling for MTP, she has to go for taking the bedaquiline containing oral longer regime. Also, in case the female is more than 20 weeks of gestation, in those cases, again, the oral longer bedaquiline. So with that, you almost cover most of your topics from diagnostic algorithm under the beautiful National TB Elimination Program and the new treatment strategies under the National TB Elimination Program. So with that, I think we have covered almost all your questions on the diagnostic algorithm under the beautiful NTEP, National TB Elimination Program, and the various treatment regimes that we have in the NTEP. Next in line is, sometimes the examiner may ask you, beta, question number 2, about the TB treatment in special situations. Please note that the TB treatment that we give in special situation like pregnancy over here, we can give the bedaquiline containing regime. I know that bedaquiline containing regime may have some teratogenic effects of different drugs are there. But the problem with TB and pregnancy is that TB is a communicable disease. It is more infective, and TB is a bigger public health problem than pregnancy and teratogenic effects. So the drug of choice that we have is a bedaquiline containing regime, right? Now, whenever we get a female who's pregnant and unfortunately she lands up with tuberculosis, now the first question that we ask is whether the female is having the period of gestation, the gestational age of the pregnancy is more than 20 weeks or less than 20 weeks. In case the gestational age is more than 20 weeks, the only regime that we have in our hand, unfortunately, is the oral longer MDR regime. It is the oral longer bedaquiline containing MDR regime in case the female is more than 20 weeks of pregnant. Now, in case the female is less than 20 weeks, in case the female is less than 20 weeks of pregnancy, now the first thing that we can do is to advise the female to get a MTP done. MTP is medical termination of pregnancy. So in case the female gets a MTP done, then she can take either the shorter regime or she can take the longer regime based on the type of TB disease that she's having. In case the female says that I am unwilling for MTP, in case the female says that I am unwilling for MTP, now you will have to shift over that patient to the oral longer MDR containing regime. Next is another type of TB treatment, that is your question number 3. In the treatment, we're still on the treatment modalities, that there is something called as the BPAL regime. That is the bedaquiline, pretomanid, and the L stands for linezolid containing regime. Pretomanid, bedaquiline and the linezolid regime. Please note this BPAL regime has been advocated by WHO. It is under the operational research. It is taken by a few districts in India, and currently the research is on about the feasibility and the compliance and the client response to the BPAL regime. It is given only in cases where there is fluoroquinolone resistance and there is no exposure to bedaquiline or linezolid. So that is the only inclusion criteria you would like to remember for the BPAL regime. It is approved under NTEP but not given as blanket treatment, like it's not given available to everyone in the country. It is only in selected states under the operational research model. We are using BPAL regime, that is bedaquiline, pretomanid and linezolid containing regime. Question number 3 could be regarding the question number 4 could be regarding the bedaquiline. What are the inclusion criteria? Who all persons can take bedaquiline? Please note that bedaquiline has a risk of cardiac arrhythmias. So the patients who are with cardiac arrhythmias but it is controlled or stable, or there is no cardiac disease is one of the inclusion criteria. The patient should be non-pregnant and the patient should be age more than 6 years. Very recently, just a couple of weeks back, there has been some research which is going on about use of bedaquiline even to age less than 5 years, but that still is under research beta. Currently, the NTEP says that bedaquiline should be used in age more than 6 years. Both bedaquiline and delamanid, both to be used age more than 6 years. Earlier, it was only after 18 years. Delamanid after 6 years, but now it is both can be used till after 6 years in non-pregnant females and patients who do not have any cardiac abnormality. Even in case they have arrhythmia, it should be a stable arrhythmia. So what are the contraindications of bedaquiline? That comes to the next point. So the next point would be, what are the contraindications? Like, what are the exclusion criteria? Common sense, any patient who has lot of arrhythmias. So any patient who has cardiac arrhythmias, conduction or the prolonged QTc F interval of more than 500. In case the female is pregnant, or in case there is torsades de pointes, features of any heart failure, or there is electrolyte imbalance also. Bedaquiline is known to cause electrolyte imbalances. So if there is evidence of hyponatremia, hypokalemia, family history of long QT interval, which again may precipitate with the for arrhythmias, this is exclusion criteria for bedaquiline. So now, next point is, like, what are the side effects of these new drugs that you might have learned? We already talked about bedaquiline. Of course, we have talked about bedaquiline that there could be electrolyte imbalance. There could be any cardiac failures. There could be precipitation of arrhythmias. We also saw that bedaquiline is actually contraindicated in pregnancy, but it is given in case the pregnant female got TB. So whenever a pregnant female gets TB, we know that bedaquiline may have some effects on the mother and on the baby. But TB, I told you, is a bigger public health problem, and that is the reason we are giving bedaquiline. So it is obviously contraindicated in pregnancy. We have discussed that. But under the under the pregnancy and TB NTEP program, we are giving bedaquiline and advising for the medical termination of pregnancy also. What are the other side effects which we need to keep in mind? Please note that clofazimine may cause dark brown discoloration of the skin, and it is important about linezolid. Linezolid, which is there in the all oral longer bedaquiline containing. You remember linezolid was given? Linezolid has a typical feature that it causes optic neuritis, and that is the reason that before we have to put the patient on oral longer bedaquiline containing regime, which includes linezolid, we should have ophthalmic examination, a thorough ophthalmic examination. And then cycloserine is known to cause some psychiatric manifestations, seizure disorders, or severe depression. So before we put these patients on any oral shorter bedaquiline containing regime or the longer bedaquiline or even the drug sensitive TB, these are the set of tests which are routinely done. So we normally have to check for the complete blood count, the urea creat, the kidney function test, the urine test in case of the females who are reproductive age group, the liver test, thyroid test, and the urine routine. Alongside for some of the other newer drugs, we need to do ECG. Why ECG? Because we already talked about bedaquiline, it has cardiac arrhythmias. Ophthalmic examination, ophthalmologist opinion, that is for linezolid. Serum electrolytes, again for bedaquiline or delaminid or the pretominid. Serum proteins, out of which albumin is one of the most important determinants, albumin, globulin, and all the total proteins. Audiometry was initially one of the mandate, but now it has been removed because we are not giving the injectable drugs, and psychiatric evaluations in case required or any surgical evaluation. So these are some of the pre-evaluation systems we have. With that, we finish this module. We have talked about the diagnostic and the treatment. In the next video section, we are going to talk about newer strategies under the program, about the care and the support system, and about organization and treatment. Thank you so much.